from sepsis and TB to something a little more common for all pathologists is biochemistry. And subject of interferences is something which I think we still don't know completely well, and we have an expert here with us, Dr. Chakraborty. He is the Chief Consultant, Department of Clinical Biochemistry at the Peerless Hospital and B.K. Roy Research Center in Kolkata. He is a postgraduate in biochemistry from West Bengal and also a fellow of the National Academy of Clinical Biochemistry, USA, and also a professional member of the AACC besides other bodies. He has numerous publications to his credit, and he's also been awarded the prestigious AACC Outstanding Speaker Award in 2013. I invite Dr. Chakraborty to share his experiences of monoclonal interferences in clinical chemistry.
Thank you, Dr. Sanjay, for the kind words. And today's talk is specifically on the monoclonal protein interference. I'm sure you are all about your interferences and interference, you are all aware of it. But we will not take anything like interferences from our spouses, interferences from our bosses, because I don't have any solution to it. But I'll specifically deal with the interferences that we face in daily laboratory practice. So here is a case study of a 58-year-old man who basically presented with a shortness of breath, weakness and anemia. And the peripheral smear showed a normocytic normochromic type, and his WBC counts were absolutely normal. So, he had a bit of renal impairment, and that is the reason why he was, after doing an urine albumin, we referred the patient for a renal consult. And, the nephrologist, these are the standard tests. When they have the creatinine result, they give his calcium, phosphate, and uric acid. So, this is what the results came out to be. Everything was roughly within range, except a phosphate of 28.4 milligram per DL. And I was a very new consultant at that time. I had never seen such a result. So would you like to try that? What might be the cause of such extreme hyperphosphatemia? Okay, doesn't matter. Before I answer this question, let's deal with spurious lab results. Whatever specialty of lab medicine we work in, be it pathology, microbiology, biochemistry, spurious results, values, abnormal values are a part of our life. And the challenge remains is to identify and not letting those results being released. And there is something which I would like to focus on is the reputational risk, because a lab is known for its report. And if you can't explain something which is bizarre, it's very difficult to save our skin. So reputational risk is something which is present in every lab. Now, our job as a laboratory physician is to prevent such results from being released. Now, we have eminent pathologists here, and I don't need to cover much on monoclonal gammopathies, except that they are basically a disorder of a single immunoglobulin secreting clone of a plasma cell population, and they are of IgA, IgM, IgA type. G and A types are the most common. There are other disorders which are also associated, which include amyloidosis, Waldenstrom's, and certain lymphoproliferative malignancies also secrete monoclonal proteins. Now, coming on to my first case, this was a case of actually a patient suffering from IgG kappa monoclonal gammopathy. Now, IgG kappa is very well known to interfere with the conventional phosphate assays that we all use. Whatever equipment you are using is liable to such kind of weird interferences, and as a result of this specific IgG kappa, it resulted in a absolutely incorrect phosphate result. Basically, after reading literature, we were able to diagnose and we were able to reflexly test for a total protein albumin followed by electrophoresis. And we made a diagnosis of multiple myeloma, which was later confirmed with a bone marrow just on the basis of this abnormal result. So now let me take you back to history, and can I have this video, please? I'll just take you 50 years ago to Los Angeles County Hospital, which had one of the world's first
at the University of Southern California in 1966. The quality of the film is not great, but it does depict much of what was going on in clinical chemistry during that era. This is the main building of the LA County General Hospital. The workload for chemistry was carried out, nearly all of it on Technicon Autoanalyzer 1s. Each AA1 was assembled on a small trolley with all the reagents for a particular assay on the shelf underneath. Each one could be disconnected and moved away. Here you see Dr. Sterling disconnecting the power and the data cord from the AA1 so that it can be taken out of service or wheeled away for maintenance.
So this is what was 50 years ago. The principles of automation have changed. But what hasn't changed is the basic principle of chemistry. Our reagents remain roughly the same. All what has happened is that we have customized things on a miniature automated smaller platforms. Now that was the autoanalyzer SMA A1. You know, that one single trolley could do just one assay. The principles of phosphate assay till date remains the same what was used in the Technicon. Analyzers have changed, basic chemistry hasn't changed. Now why these cases of spurious interferences in cases of monoclonal gammopathy have turned up in literature in the last 20 years was that previously all the analyzers like SMA and the later ones used to assay analytes after deproteinizing them. So this protein, we used to measure things in a protein-free filtrate. So we never saw such kind of interferences in the 60s, in the 70s. Only when we started using serum or plasma directly, we found that, from 1980 onwards, you will see all these reports. They were present previously, but were never picked up because we assayed everything in a protein-free filtrate. Now, here is what happens inside an autoanalyzer. The one is just the phosphomolybdate reagent in a cuvette. What happens when we add an IgG kappa sample to it? You can see the white precipitate being formed here. And it's an enlarged. This is the large precipitate which is formed. It forms in a flash of a second. The analyzer reads it as an absorbent spike and gives you incorrect phosphate results. Now, pseudo hypophosphatemia is very common. It's quite common. Up to 1 in 4 samples of patients of IgG kappa monoclonal gammopathy, and IgG kappa is one of the commonest, can show such kind of interferences. Now, you cannot predict this interference because at what concentration of total protein you will have this interference remains unknown. There is one more aspect, that is pseudo hypophosphatemia, where instead of having a very falsely elevated value, we get a lower value. That is known as pseudo hypophosphatemia. In my case, I got a bizarre value. But had the value been reported as something like 9.5, 10.5, I would have released the result. If the result was a low value, 2.5, I would have possibly released the result without knowing this. So we need to be very aware of such things can happen in patients with multiple myeloma. And all the wet chemistry platforms that we use, whichever is the manufacturer, are susceptible to this interference. It is across board. Now here is one more interesting case. The cases that I will show you are either, all of them are from my lab or are published from our hospital. So this was a case in which, we reported a bilirubin. We found the total bilirubin was raised and a direct bilirubin was normal. And an adult patient, it almost looks like that he's having hemolytic anemia. Now the commonest culprit in spurious bilirubin results is the total bilirubin which is usually affected is either IgG lambda or in some cases it is IgG-M. So bilirubin is the second commonest analyte which is subjected to interference. Now this is what in figure 1a, the first 1a is a normal sample, B is an icteric sample, and C is a sample which contains, it's of a myeloma patient. Now this is the total bilirubin reagent. What happens in A is that there is no color formation. This is true bilirubin. The correspondingly you can see the purplish color which is developed. What happens in a myeloma protein is that there is no color formation, but due to again that precipitation effect of that monoclonal immunoglobulin, we get haziness. And again the analyzer is fooled and it reads a weird absorbance and we get a total bilirubin of 18. However, when you look at the sample, you will see that it is crystal clear. This is one more case that we encountered in a patient with Waldenstrom's macroglobulinemia. In Waldenstrom, typically IgM type immunoglobulin is expressed and the immunoglobulin levels are very high. So we got a case of spuriously low HDL levels of 11 milligram per DL. When we used a different methodology, we found that the HDL cholesterol was actually 40. Now it is not always that all wet chemistry system, all liquid chemistry based systems will behave abnormally. It is something which is specific for the assay, but all of them are subjected to these kind of interferences for different assays.
What was the alternate method you used?
In this case of the HDL one you are talking about, HDL one we found the interference on a Beckman-Coulter system and the Roche system gave the right result. In the bilirubin system, it was very interesting case. In the bilirubin case, Roche's, I actually do not like to disclose the names of the company, but it was the same manufacturer. On one of its system, there was interference. On the higher end model, there was no interference. It was because the same manufacturer has two different blanking principles for each different analyzer. So one was interfering, the other wasn't. And in all these cases, we verified, particularly in the phosphate and I'll come later on, we actually collaborated this with dry chemistry findings. We used the ortho method for this. I'll come to that later on. I'll also show some strategies by which you can detect these things. Now this is a very interesting a diagnosis of a light chain myeloma, which you can see from the immunofixation